Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Madrigal Pharmaceuticals.
It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer.
Hello, and welcome to this Medscape webinar entitled Current Concepts in MASH Treatment. This webinar is being supported by an independent educational grant from Madrigal Pharmaceuticals, and we would like to thank them. I'm Dr. Stephen Flam, Professor of Medicine in the Division of Digestive Diseases and Nutrition, and Director of Clinical Research in the Section of Hepatology at Rush University Medical Center in Chicago. And I'm very pleased to be joined by my co-panelist today, Dr. Tejas Joshi, who is a hepatologist and obesity medicine specialist, adjunct clinical instructor in the Division of Gastroenterology and Hepatology at Marshall University in Huntington, West Virginia. Welcome, Tejas.
Thank you for having me.
Over the next 30 minutes or so, we're going to be discussing a very important topic in your practice, the management of metabolic dysfunction-associated steatohepatitis, or MASH. Tejas, before we get into our discussion on MASH treatments, could you start by explaining to our audience what MASH is, how it differs from MASLD, and why it's so important to intervene before MASH progresses to cirrhosis?
Sure. Thank you, Stephen. So with MASLD, you have the liver filled with steatosis or fat, but no injury. Once that injury pattern sets in, and you have some histological changes, such as hepatocyte ballooning, lobular inflammation, that inflammation then drives what we call as MASH. Early MASH, we will not see significant fibrosis. Then after that, you will see that fibrosis begin to build and you will develop moderate to advanced fibrosis, or F2, F3. And then that progression of fibrosis sets you up for the risk for cirrhosis and its complications. One of the important key takeaways here is that over 100 million Americans are suffering with steatotic liver disease, and about a third of them, roughly 27 million to 100 to 30 million, are going to develop and be at risk for MASH. And then those patients will progress to MASH cirrhosis, or F4. And it's very important to intervene as fibrosis stages 1, 2, and 3 are reversible. Risk factors for MASLD with fibrosis. We need to identify those patients as diabetics or those with abdominal obesity with at least one cardiometabolic risk factor, or those with persistently elevated liver enzymes need a thorough workup. And these certain subgroups, which may include Hispanics or certain Asians, or even a lower BMI puts them at risk for MASH, need to be identified early as they hold an increased risk. Stephen, how are patients with MASH at risk stratified, and how does that influence both the management of their MASH directly and management of associated cardiometabolic comorbidities?
Thank you so much, Tejas. You said some very important things in your last few slides. One that really illustrates why this is so important for everybody in this audience, whether you're a primary care provider, an endocrinologist, obesity medicine specialist, gastroenterologist, or hepatologist. We think 100 million people in the United States, almost 1/3, have MASLD, and 1/4 of them have MASH, not everybody. Those are the ones at risk to get fibrosis, the MASH patients. Unfortunately, the only way you actually know if a patient has MASH is to do a liver biopsy, which we don't normally do. What we do, though, is you in your practice can determine without a biopsy how much fibrosis, scar tissue a patient has in their liver. And that's how you can identify patients that are at risk to develop cirrhosis, patients that we do need to intervene on, and patients that may actually require medical therapy. Now, when you in your practice identify somebody that has MASLed, they had an imaging procedure, maybe because they have elevated liver enzymes. Many patients with MASLed have normal liver enzymes. That should not encourage you. Many people have advanced liver disease with a completely normal liver panel. So anybody with fatty liver, you should take very seriously. And what we do with all fatty liver patients, whether they have steatohepatitis or not, whether they have fibrosis or not, is we need to encourage ways for them to get better. And this slide and the following slide illustrate that. First of all, we advise lifestyle interventions for all of them, including cessation of alcohol use. Tejas just mentioned to you some of the risk factors to develop MASLed fatty liver. And the major one is obesity, and structured weight loss programs and or anti-obesity medications are very helpful. Bariatric surgery can also be helpful if otherwise indicated. You want to control cardiovascular disease risk factors because these make fatty liver worse. That includes, as was already mentioned, hyperlipidemia and type 2 diabetes mellitus. So we need to be very proactive in intervening for patients in terms of managing their cardiometabolic risk factors. And their lipids should be managed very strictly. Statins are safe if indicated. There are no contraindications to using statins in patients with fatty liver, or really any other liver disease for that matter too. Now, you don't have to send every single fatty liver patient to a gastroenterologist or a hepatologist. If a patient has fatty liver and you determine that they don't have much hepatic fibrosis, with testing, you can manage them by following them on an annual basis and rechecking their fibrosis testing on an annual basis. When they start to develop higher risk, when they start to develop at least stage 2 fibrosis, which is a moderate amount of fibrosis. By the way, stage 3 is severe and stage 4 is cirrhosis. Anyone with 2, 3, or 4, those are patients that are best managed, if possible, by a gastroenterologist or hepatologist. And when we see those patients, we do the same things you do in the first place. We advise lifestyle interventions such as cessation of alcohol use. We advise weight loss. We advise bariatric surgery if possible. By the way, patients that have decompensated cirrhosis, meaning they have ascites or encephalopathy or varices, they are not eligible for bariatric surgery. We also very aggressively still control cardiovascular and cardiometabolic risk factors. And again, statins you can still use. Tejas. As we saw on these previous 2 slides, lifestyle interventions and weight loss are critical components to the comprehensive management of MASH. And in fact, the 2 FDA-approved MASH therapies, which we will discuss in a few minutes, are indicated to be used in conjunction with diet and lifestyle interventions, not instead of. How do you approach this in your practice?
So, thank you, Stephen. I must reiterate that lifestyle is the cornerstone of MASH management. We'll start off by saying that anybody with liver fibrosis should abstain from alcohol. And that is less than 2 drinks for women or less than 2 to 3 drinks for men if that was without fibrosis. But if you have liver fibrosis, you must abstain from alcohol because that is adding oil to the fire that has already been lit by MASH. In regards to the importance of managing comorbidities, we'll go through each one. Number 1, insulin resistance. One of the ways we can combat that is through using weight resistance and by increasing muscle mass and ensuring that patients are optimized on therapies like metformin and other GLP-1s and other medications like SGLT2 to improve their insulin resistance, ensuring that we recognize that they have metabolic syndrome, and then going after each of those different cardiometabolic risk factors and optimizing their therapy. Obesity. It starts by focusing on diet as well as exercise. For diet, dietary changes would include reducing refined carbohydrates, sugars, or ultra processed foods. And then portion control. Portion control can be having multiple small meals throughout the day or utilizing something like time restricted eating and having maybe one or two meals like breakfast and avoiding maybe lunch and then going back to dinner. And ensuring that each of those we have a very balanced diet with both carbs, healthy fats like in avocados, as well as high protein. Weight loss, providing our patients with goals because we know that if you have at least 5% of weight loss, you improve steatosis. 7 to 10%, we reduce that inflammation seen on biopsy that I mentioned to you, and we see an improvement of liver enzymes. And then when we reach that greater than 10% weight loss, we can actually begin to reduce and reverse liver fibrosis. This, done in conjunction with pharmacotherapies we'll talk about, is going to be the cornerstone and treatment of MASH. Impact of weight loss on MASH. I've talked to you about the certain weight cutoffs and how we can start to see the steatosis improvement. We can start to see at 5% improvement of ballooning and overall inflammation, seeing that lobular inflammation we may pick up on biopsy. MASH resolution is going to start to be seen when we reach greater than 7%. And patients are going to have that fibrosis regression when we reach greater than 10%. But once these cutoffs are reached with both lifestyle and exercise, maintaining is going to be very important. Sustainable treatment strategies, because we're going to see a metabolic adaptation at the arcuate nucleus within the hypothalamus. Once that weight is lost, when we have been sitting at a certain weight for a significant period of time, there's a set point there. And so our body wants to drive us back to that weight that it felt was a comfortable place to be. And we will see that there's a reduction in leptin and an increase in ghrelin. These are going to drive metabolic adaptations to try to bring you back to that weight you once were. So it is very important to recognize that weight loss is important, achieving these targets are important, and then finding strategies on keeping that weight off.
Pages. As I alluded to earlier, we now have two FDA-approved therapies for MASH: oral resmetirom and injectable semaglutide. Both, though, are specifically indicated only for patients with stage 2 or 3 fibrosis, not stage 0 or 1, which is no or minimal fibrosis, which the vast majority of patients have who have fatty liver and MASH, and not for cirrhosis either, which is stage 4, stage 2 and 3. Can you tell us briefly how these drugs work and how they are prescribed?
Sure. So with resmetirom, this is specifically a thyroid hormone receptor beta agonist. Now we know about the thyroid hormone receptor alpha. This is quite ubiquitous throughout the body. It can be in the bones, in the pituitary gland, but thyroid hormone beta is very specific to the liver. And we know that there's a dysfunction of this, and because of that, you have a buildup of inflammation, a deposition of fats, and the mitochondria begin to dysfunction, and that further drives inflammation. By then utilizing a medication that's liver directed, like resmetirom, we can activate this thyroid hormone receptor beta, and this improves that mitochondrial function. And then through that, we can have a reduction of intrahepatic triglycerides and fat and a reduction of liver inflammation. This medication was approved back in March of 2024, and it is indicated for those with moderate to advanced fibrosis, which I use interchangeably with F2 or F3. This is a weight-based dosage, and for example, if you're greater than 100 kilograms, you'd get the 100 milligram tablet. If you're less than 100 kilograms, you'd be on the 80 milligram tablet. Now, one caveat here is that if you're on a CYP2C8 inhibitor, such as clopidogrel or Plavix, whatever weight-based dosing you'd be on, you'd reduce that by 20 milligrams. So if you were 90 kilograms, you should be on the 80 milligram dose. Now, semaglutide, Now, the L cells of the ileum secrete the GLP-1. And we know that there's receptors throughout the body in the brain where we have the master regulator. We have an improvement of the reward center, and we have a decrease in that reward pathway. So patients see decreased food noise. At the same time, we also see that the gut is affected through this as well. So we may experience early satiety, and through this we can drive weight loss, and we can see that this is indicated for MASH for those F2 and F3 because you're going to achieve those weight loss goals. And dosage for this starts at 0.25 milligrams weekly, and we increase this in a stepwise fashion on a monthly basis based on tolerance. If a patient is unable to tolerate a dose, you can take a step back and keep them on that dose that they are tolerating for an additional month and then increase then. And if they are unable to tolerate the actual indicated dose of 2.4 milligrams weekly, then they can be lowered to 1.7 milligrams if not tolerating. Stephen, could you talk about the two pivotal trials for resmetirom and semaglutide and MASH and what they found?
Sure, Tejas. Now, these trials only looked at patients with stage 2 or 3 fibrosis. This is the subset of patients with fatty liver that we think are at risk to develop cirrhosis. And this is not a surprise. If they've already developed moderate to severe fibrosis, if they've already demonstrated that to us, then those are the people, of course, we would think that would later develop cirrhosis. And here's what happened. In the placebo group, approximately 10% of patients had resolution of the steatohepatitis, and the fibrosis stayed the same or got better. About 10%. Presumably, they had better control of their lifestyle with weight loss and very good control of diabetes and cholesterol. But in the treatment arms, and there were two, one was 80 milligrams a day and one 100, the achievement of the success metrics here, resolution of MASH and no worsening of fibrosis, was about triple compared to placebo. And this was statistically significant. Now, when you look at the second outcome measure, where fibrosis actually improved, the holy grail for treatment of liver disease, and the MASH, the steatohepatitis, either stayed the same or got better. It was actually 14% in the placebo arm and 24 to 26% in the treatment arms. So approximately a doubling of the response. Again, reaching statistical significance. The drug also was shown to decrease hepatic fat content. It also had a secondary effect of decreasing LDL cholesterol. And if you're wondering about tolerability, the treatment emergent adverse events that were in excess of placebo were primarily mild GI events. This drug was very well tolerated. Now, the semaglutide trial was called the Essence trial, and it was very similar to the Maestro NASH trial that we just discussed with resmetirom. The only difference is this is semaglutide, and as I'm sure many of you know, when you're on that drug, the dose has to be ramped up, and it was ramped up over a 4-month period to get to the optimal dose. And then that drug was continued for a total of a 72-week course, a year and a half. As you know, if you don't ramp up the dose, there is a lot of GI toxicity, which limits usage of the drug. And when you looked at this in this trial, same outcome metrics, placebo group here had 34%, about 1/3 of the placebo patients actually had resolution of steatohepatitis and no worsening of fibrosis. But in the treatment arm, semaglutide, it was approximately 63%, approximate doubling of the response. Again, reaching statistical significance. When you look at the other metric, improvement of fibrosis, and the steatohepatitis staying the same or getting better, it was 22% in the placebo arm and approximately 37% in the treatment arm. Again, reaching statistical significance. And for this reason, in August of 2025, as Tejas just mentioned, semaglutide was also approved for treatment of patients with steatohepatitis and stage 2 or 3 fibrosis.
So, a question that I want to ask you is now that we have these treatments available to us, how do we select patients for MASH directed therapy? What do the guidelines recommend?
This, of course, is a very important question, Tejas, for the practitioners that are in the audience, because we do not do liver biopsies on these patients to confirm steatohepatitis in stage 2 or 3 fibrosis. What we do is when we have a patient with steatosis on imaging, like ultrasound, CT, or MRI, we then assess fibrosis with non-invasive tests, not a biopsy. And you can do them either with blood tests or with imaging tests, which are based on a principle called elastography. Now, I know to the audience it might sound complicated, but it's not really. There are several blood tests that you can get in practice. Some of them are free. You can just Google them, APRI and FIB4, and some of them you have to order, like FibroSure and the ELF test. The ELF test of all the blood tests is the best, the most accurate for assessment of hepatic fibrosis, really in all liver patients, but we're talking about MASLD here and MASH. So you can order a blood test in practice, the ELF test, and it gives you an assessment of whether or not a patient has fibrosis. And if the score is between 9.2 to 10.5, those are the numbers that we think convey a diagnosis of stage 2 or 3 fibrosis. Now, imaging, elastography, tells how elastic a liver is. When a liver has no fibrosis, it's very elastic. When it has a lot of fibrosis, it's not elastic. And there are several elastography tests that we can order. The best one is called fibration controlled transient elastography. The second is an MRE test, which is less available and more expensive, although the most accurate. If you do vibration-controlled transient elastography, if you have a score between 8 and 15, we think that conveys also a diagnosis of stage 2 or 3 fibrosis. So if you use one of these two methods, blood tests or elastography assessment, you in practice can determine if your fatty liver patient has stage 2 or 3 fibrosis. And I want to emphasize again, this is one of the most important messages, I think, tonight. Patients can have normal liver enzymes and still have very advanced liver disease with MASLD. Do not get tricked to looking at liver enzymes and thinking the patient must be fine because the liver tests are normal. Now, sometimes we even extend those criteria. If someone's FibroScan assessment is 15 to 20, that is bordering on cirrhosis. The MRE, if you have a score of 4.4 to 5, that is bordering on cirrhosis. If your ELF test is 10.5 to 11.3, that is bordering on cirrhosis. And you then have to make an executive decision in practice whether or not to use either of these drugs in that setting, because again, you are not supposed to use it in patients with cirrhosis. It is not yet recommended. There are studies, by the way, ongoing, but the drugs are not yet approved for cirrhotic patients with MASH. Tejas, beyond the guidelines, how do you discuss treatment options for your patients? And what other factors go into your decision?
Aside from looking at the patient's insurance, affordability, access, which we're all going to look at for all of our patients, our goal is we need to quell that inflammation in the liver, reverse that scarring. We want to prevent that complications. And we need to look at the patient's ability to do injections. Maybe they're afraid of needles. Maybe they prefer a pill. So looking at the patient's choice of if either way could be, if they had F2 or F3 and they preferred pills, then I may choose resmetirom. If they're okay with injections, I may choose semaglutide. Other ways to look at it is the patient suffering with obesity. There are some variants such as lean MASH, where the patient has a normal BMI, but yet they have other comorbidity conditions such as diabetes or dyslipidemia, where we know that resmetirom, which is liver directed, may have a benefit here. Or if their diabetes is uncontrolled and they're already on metformin and they need further optimization, I may choose semaglutide. So, discussing what the patient's desire is, what type of treatment options, and also looking at the fact of how close they are to bridging into cirrhosis, that's how I may consider the strengths and weaknesses of these medications and try to apply it and kind of personalize it towards the patients. Stephen, we've talked about how resmetirom and semaglutide are prescribed. But how do we then monitor a response when patients are on these agents? Does this process differ between agents? And how do you do this in your practice?
Those are great questions, Tejas, because once you as practitioner selects a patient for this, an appropriate patient for this drug, there are two big questions we get. One is how do you actually monitor patients and determine if it's working? And secondly, do you ever stop therapy and when would you? As far as follow-up, when you're on either of the drugs, resmetirom or semaglutide, you want to follow labs periodically, including the liver panel, and you want to reassess fibrosis in 1 year. 1 year. And you hope to see improvement. If there's improvement and the patient's tolerating the drug, you keep it going. If there's a little bit of improvement or even a little bit not improvement, but within 25 to 30% of the old score that you had, the original score, we usually continue therapy and maybe add on a second therapy, although there are no data yet to support that. Finally, if clearly the hepatic fibrosis score is worse, and there's a very good paper that from a lot of the society leaders in this field that say if the fibrosis score is more than 30% worse than it was to begin with, that's when you would consider stopping or switching or doing something else. Tejas, what is your process for monitoring patients on resmetirom and semaglutide?
Well, before initiating, for monitoring patients on resmetirom, I get a basic liver chemistries, thyroid panel, lipid profile, and I get my non-invasive measurement of liver stiffness. I don't have access to MRI PDFF at my institution, but if you do, you may want to consider this. Once the medication has been initiated, at the 3-month mark, I'll get a repeat liver chemistries, and then at 6 months and at the 1 year mark. And at the 1 year mark is when I repeat the non invasive measurement of liver stiffness. And I kind of utilize that as a way to track our patients to see if they've either maintained their liver stiffness, improved, or worsened. In regards to those patients on semaglutide, one thing to recognize is the GI side effects, and as well as reflux is one of those. So ensuring your patient is on an appropriate PPI, as well as ensuring that patients have access to antiemetics like odensetron, looking at their sugars, also monitoring that as they're losing weight, that they're not developing significant sarcopenia. Now, some recent studies have shown that the muscle loss within skeletal muscle sarcopenic loss is not that great, that the muscles themselves actually lose the fat within it, but overall muscle loss is not significant. But it's important to recognize that they may have GI side effects, that they have access to medications that help treat through this, and that if a patient of yours is having right upper quadrant pain, that patients with semaglutide can develop stones. So you may want to consider getting a right upper quadrant ultrasound. And also that this medication is not indicated for those, either of these medications. If they're interested in family planning and getting pregnant, you would also then do a pregnancy test. And if any of our patients are thinking about having children, then within 3 months of even starting that, I discontinue these medications as they haven't been studied.
Hey, just again, that's an excellent review. I have a couple questions for you as we approach the end. As far as when do you stop MASH-directed therapy? Tell me when you would stop it, these medications, for instance, and then I can tell you what I do in my practice.
Sure. Yeah, no, this is something that comes up quite often. If we as providers are not thinking about it, then the patients are asking us. A patient may go from F3 to F1, and then the question comes down to, Have we actually moved the needle in their comorbid conditions, their cardiometabolic risk factors? Have we optimized their A1C? Are they goal? Is their lipid panel at goal? Because if their blood pressure is not controlled, if they have high triglycerides, if you've optimized them on their treatments and they're still at risk, then therapy cessation may lead to then recurrence of fibrosis or once again worsening. And so, although a patient may go from F3 to F1, you have to recognize, have we optimized them on the treatment of their other comorbid conditions? How about yourself? How do you approach this?
There's two times when you would stop therapy. One is, of course, if the drug's not working, and that would be, again, the fibrosis is getting worse, or the patient doesn't tolerate the drug, which is very rare, by the way, in practice. And the other one you might consider is if it's working so well, you don't need it anymore. I, for one, for the most part, don't think that's a good idea. This is a metabolic disorder. The risk factors usually remain diabetes, cholesterol, obesity. So I don't think, even if the fibrosis improves, that you should stop the drug. But I guess you could conceive of a scenario where a patient lost 50 pounds, their diabetes resolved, their cholesterol is improved, and their fibrosis is much better, that maybe you would stop the drug because it was working well. But I think in general, we should keep the drugs on board if they are working and if the patient's tolerating them. Tejas, this has been a great discussion. I would love to thank you for joining me today, and I'd like to wrap up with a few concluding remarks. There are two MASH-directed pharmacotherapies, resmetirom and semaglutide, that are FDA approved and have demonstrated efficacy for treating stage 2 or 3 MASH. Patients can be identified and selected for these therapies with non-invasive fibrosis testing using established, easy-to-understand algorithms. Treatment selection should be tailored to the individual patient and account for patient goals and preferences, comorbidities, and tolerability. And despite the presence of these drugs, do not forget weight loss and lifestyle interventions. And that includes controlling glucose and lipids. This is imperative for all patients with MASH, including those on FDA-approved MASH therapies. I would love to thank everybody for attending our program tonight about MASH and treatment with the two new FDA-approved products for stage 2 and 3 fibrosis. And if you want more information on MASH, including clinical advances, please look at the website from Medscape. It is an outstanding source for clinical information for you that you, as a provider, can use in your clinical practice. Thank you again for attending.